who are online. My name is Holly Fernandez-Lynch. I'm an assistant professor of medical ethics, and I'm the reps co-chair along with our department's chair, Steve Jaffe. Today, we're excited to welcome our own Atheendar Venkataramani, who is going to discuss his IGNITE study, a cluster randomized trial testing an unprecedented big push effort to improve health outcomes in predominantly Black communities in Philadelphia. So I'll introduce you in just a second. I'm just going to make a couple of quick announcements. We are recording this session, which hopefully just got announced to everyone, and it will be made available on the Medical Ethics and Health Policy website in a couple of weeks. We will continue to host reps in this hybrid fashion going forward. We have one lecture remaining for fall. So on December 5th, we're going to host Rita Redberg, who's the editor of JAMA Internal Medicine. She's going to be giving a lecture on safety and innovation in medical device regulation. And then you can see our spring 2023 schedule is also set with a bolded reminder there that we are moving to second Wednesdays starting in the spring. So if you hold that time on your calendars, and Mary Pham will continue sending out the announcements for each session. Oh, thank you. You can just hit that. Yeah, great. Now, a quick reminder about some of the online resources that we offer through our department. We have a series of short research ethics courses, all available for free. Continuing education credit is also possible, and you can use some of these to satisfy the research ethics training requirements imposed by Penn and by CHOP. If you have any difficulty figuring out how to have those entities accept this training, I can point you in the right direction. It's clear on our website, but on their IRB websites, you have to scroll and go through a bunch of carrots to get to where they say it's okay that you can use those trainings. And then finally, I just want to thank our reps co-sponsors. Thanks always to Mary Pham for making sure everything goes so smoothly. And today, thank you to Emily Walters, who's holding down the fort while Mary is doing jury duty. So very briefly, let me go ahead and introduce today's lecturer. Double Doctor Atheendar Venkataramani is a health economist who studies the life force origins of health and socioeconomic inequality. His research focuses on elucidating the effects of early life interventions on adult health and well-being, understanding the relationship between economic opportunities and health behaviors and outcomes, and examining spillover health impacts of social policies in both domestic and international settings. I am a huge admirer of your work. I'm really thrilled to hear a bit more about what you've been working on. So take it away. Thank you.
All right, so thanks for having me. I'm excited to talk about the IGNITE study, which I'll describe through the course of this talk. Just so you know, this is a cluster randomized clinical trial that was funded by the NIH Common Fund Office of the Director. And we did, just so you're aware, we got Institutional Review Board to proceed with the study at the end of the summer. And the study is actually underway in terms of recruiting, and we're doing some of our first home visits today. So I'll describe what all that means in a second, but it's early, but it is a great time to get feedback because we've just enrolled probably 12% of participants. And it's the kind of study that I think would benefit from lots of eyes. Okay, so I was excited to present here because the ethics of trials like this always comes up, and I've never been satisfied by this conversation. So this was on LinkedIn, which is I guess the social network we'll all use after Twitter dies or something. But someone at Penn was very nice to post a news article about the funding coming to Gina South and I, who's the principal investigator with me on this trial. And someone had a comment, which was, this is really top down. It's like wealthy people like experimenting on poor people. Aren't you basically propagating this dynamic that you're trying to actually address? It's a fair question. So I responded, we're not trying to do that here. We have a number of things that we try to build in the design of the study to prevent this possibility. And the response was, well, the dynamic of being studied is one of massive power differential. I worry about the many ethical conundrums, issues of consent, and multitude of harms from this sort of work. And so again, fair points, potentially. I asked what those were specifically, and I never got a response. And I've had a number of interactions like that where it's, like I spoke at the CDC about this trial, and it was, what about the ethical concerns that, with regard to doing a study like this, but none were really articulated to me. And so I would love for you guys to articulate them if there are any. And that's the advantage of being a department that has like this incredible kind of ethics division. I also want to say that these ethical dilemmas that kind of come up with regards to trials like this, there's a parallel conversation happening in global health about this very thing. What does it mean for people from US universities to intervene in settings where they don't have any knowledge, they don't have the context, and even with some type of partnership with local authorities, there's a power differential that may actually lead to the influence, unbalance of partnership in ways that can create harm. So I think this is a larger, important conversation. We'll try to tell you all the things we try to do. It's important to me to not have that ethical kind of dilemma and that power dynamic appear here in an adverse way. We'll tell you all the things that we try to do to limit that. But of course, there are things that we may not have thought of. And so I'm hopeful that we can talk about that. So I think it's worth motivating the study first. It both, I think, highlights the potential harms that this person was talking about, I think, as well as why we would do a study like this in the first place, right? So you can start thinking about risk and benefit with this slide. So on the left is these are census tracts, and it's a map of Philadelphia, and it's the proportion of the population in that census tract in the 2019 American Community Survey that is Black. So you can see that in West and North Philadelphia and some parts of South, there's a very high concentration of Black residents, and it's quite segregated within the city, right? So there's a ton of residential segregation in the city that you're all aware of. On the right is a map, kind of in a more neighborhood sense, that's looking at mortality, right? So in both of here, red is concentration of Black residents, and in the map on the right, which is about age-adjusted mortality per 100,000, the red is going to be where mortality disadvantage is concentrated, where mortality is higher. And so what you see is that in the neighborhoods that tend to be predominantly Black, there is this very high correlation with age-adjusted death rates. Why is that the case? So a couple things. In addition to being highly segregated, if you look at Black families in Philadelphia, 31% live below 100% of the federal poverty line, which itself is kind of a low marker for sustenance in the United States. There's a whole debate about that, but let's use that number. And as a contrast, I can say 15% of white families are below that same line, right? So the poverty rate by that metric, which is not a great metric, is double. The wage gap among Black men, if you look at that, for every dollar earned by a white worker in Philadelphia, it's 65 cents for a Black. So there's a massive wage gap, which is about tracks what we see nationally, right? And that does not include people who are incarcerated. So if you put them in the denominator, that wage gap is even larger. There's a lot of need, but even with what we do to try to meet that need, there are gaps. So Black families face a number of structural barriers. They face all the features of poverty that tend to make it hard to engage with social service systems. They have a lot of things to do. They'll be bandwidth constrained as a result of the different worries they have to do to make ends meet, multiple different jobs. And so what you see is that 40% of families in Philadelphia as a whole, and it's predominantly Black families, have unclaimed benefits in public programs. One estimate suggests that it's $450 million that are left on the table. So this is kind of the feature of what's there. There's also environmental issues. So high pollution areas tend to be where there's a higher population that is Black due to a number of longstanding issues in infrastructure investments, green space investments that have led to concentration of pollutants. There's supposedly 40,000 vacant or abandoned spaces, again, concentrated in those neighborhoods that attract crime, potentially have dangerous elements directly, and are unsightly in ways that can affect mental health. So, and plus it's the potential of space that has not been used, right? Like there are things you can do to invest in that space, it hasn't happened. So that's, I think, a picture of Philadelphia. It's very stark. It can be depressing. So thinking even more, going back a little bit, a historical reason why we think this happens is something called fundamental cause theory, which the sociologists have advanced. And the idea in fundamental cause theory is that structural racism fundamentally causes health. It affects health through multiple different mechanisms. If you address any one mechanism, another one will arise to take its place to perpetuate the same advantage. That's one explanation for why, despite, I think, real gains in narrowing black-white gaps and things like life expectancy, we continue to see those gaps persist because they're forces that exist to maintain. If you take that model, I think, to its extreme, what it means is that any single intervention is not going to work at all. I think a less extreme of the version of that model says one-off single component interventions can work, but only a little bit. Their effects of any one intervention might be potentiated by other interventions that work to address all of the different arms by which structural racism can affect health. So one of our motivations is if you believe in this fundamental cause framework, then your intervention necessarily has to be multi-component, multi-domain. So that's what we tried to do with the Ignite study. So this is our model of what is happening in Philadelphia, right? So we start with our fundamental cause on the left-hand side, that's structural racism. And on the very right-hand side is racial health disparities. There are two kind of broader community level things that structural racism leads to. One is the limiting economic opportunities and increasing financial risk. And then there's a whole set of environmental interventions. And each of those pieces leads to a number of mediators: exposure to crime, direct stress, exposure to discrimination, loss of social connectivity, food insecurity, reduced healthcare access, which pattern the disparities that we see. So what Ignite is going to do is try to take on the economic risks and opportunities and the built and physical environment. That's our goal. So let me tell you just the architecture study, and then we'll kind of get into the weeds of why we did this. So what we are doing is we've identified 60 clusters. These are about 0.125 mile radius neighborhoods, predominantly, actually not predominantly, fully in West and North Philadelphia. From those clusters, we're going to enroll 12 households in each cluster, so 720 total. 60 clusters, 720 people. We're going to randomize half of those units to receive a multi-component intervention, and the other half is going to be our control group. We'll talk a little bit about what is the control group doing. That has been a point of, not contention, but a point of curiosity. So here's the intervention. The first level of intervention is at the community level. We're going to focus on environmental justice, and we're going to do 4 things. We're going to green up vacant lots. We're going to remediate abandoned homes. We're going to plant lots of trees, and we're going to clean up trash weekly. We'll tell you why we picked these things in just a second. At the household level, we're going to focus on economics. So the first thing we're going to do is we're going to hook up people to free financial counseling. We'll also hook up people to a tax preparation service that will do it for free. And then we'll hook them up to a service that allows people to sign up for benefits at their door. So they don't have to go through the Byzantine types of things that people have to do to get onto SNAP or something. We'll bring that process to them. In addition to that, we will offer everyone in the intervention group a micro grant at the beginning of the study of $400. So we're going to do that once. It's not a lot of money, but that $400 number comes from this Federal Reserve study that you may all know, which suggests that over 50% of American families can't find $400 in an emergency. So we picked that. It's probably a different number than that, but that's what we ended up going with. So that's going to be the intervention: layered environmental interventions and focused economic interventions at the house. So why did we pick this type of intervention? So a lot of why we chose these elements is based on 10 plus years collectively of the study team working in Philadelphia and doing research and working with community partners. So it's evidence-based in many, many ways. We also know that there's demand for these interventions. So our interventions are going to be delivered by not-for-profits that have worked in these communities for many years. And we know there's high demand because many of those services are in fact oversubscribed. So one of the services is actually not doing any work in West Philadelphia right now because they don't have the personnel to meet the demand. And so part of what we've done with the study is expand their budget constraints so they can. It's useful to tell you who's on the team because I think people have cared about this. So Gina and I are the multi-PIs, I guess. And then we have a team of people. George is a pediatrician who's an expert on household finances and working with these non-governmental organizations to bring those services to the door. Courtney is a sociologist who's an expert on fundamental cause theory. John is a criminologist. He's done a lot of trials with Gina and Charlie Brannan, basically doing some of these environmental interventions and showing that they have big effects on crime. He's incredible in terms of his knowledge of field studies, the city, and we also think crime is going to be one of the big mediators by which our interventions improve health outcomes. Christina is in our department. She is a health policy expert who's worked with the Department of Public Health as well as a psychologist. She's an expert on food security. Megan Ling-Fall is an expert on implementation science. So we'll talk about what that's going to look like. Chris and Lynn is a biostatistician, and Charlie is at Columbia now, but he was at Penn. He was the previous director of the Urban Health Lab before Gina. We have a number of different people who are involved, basically really running the study. So Nikki Thomas is directing the Urban Health Lab. It's just a force when it comes to community-based partnerships and really forming those connections that allow academic research to be credible at the community level. Abby and Shalanda are project managers. Shalanda actually left, but I left her picture up there because she was so instrumental in getting the study off of the ground. Some other lucky team has her now, and we are hiring a new project manager as we speak. And then Emily Seeberger is our data analyst for this for the first half of this, which is getting the study off the ground and doing the GIS maps so that our field team is able to know what houses to go to and whatnot. The data analyst who on the back end blinded to the treatment assignment will be doing all the analysis of Lizzie Baird, who I've worked with now for about 5 years. The heart and soul of the study is our community coordinator team. Andre, Reed, April, Sheeran, Ash Triba, and Craig Terry, they are all folks that come from the communities that we seek to serve. They have on-the-ground knowledge of the places that will be conducting the study. They are the face of the study. They go and they do the enrollment, they do the home visits, they're in contact with study participants to get them hooked up to the benefits. They field the surveys both at a baseline and live. It was very important for the face of the study to not be this face necessarily, just because we wanted it to really reflect the community-grown nature of the interventions. And supporting the community coordinators are the folks that have the services that we're going to deliver. The Philadelphia Horticulture Society will be doing vacant lot greening, trash cleanup, and tree planting, and we're working with the city of Philadelphia to do remediation of abandoned homes. Clarify is a service that does financial counseling, and they'll be administering the microgrants of $400. Benefits Data Trust is a group that basically centralizes and reduces the administrative burdens of signing up for public benefits at things like Medicaid, SNAP, as well as some of the more local, state and local programs. And then the Campaign for Working Families does free tax credit. So they're going to be, along with the community coordinators, they're the folks who are going to deliver the interventions. People who are known to the communities, people who can advocate for the communities and tell us where we're going wrong because I'm sitting on the 13th floor of this ivory tower, right? So that was the idea. We didn't want to be making too many assumptions. So let me just stop there. Do you guys have any questions?
Within those segments of the neighborhoods, I think you said there's going to be 12 families in each, right? So they'll all be exposed to the community level interventions, right? It's just the individual interventions are what will be randomized. And is it half and half?
So everyone in the cluster will get everything. So we're randomizing at the cluster level. Okay. Yeah. So and we did that on purpose. What we didn't want is for people to get $400 in the same cluster, but
got it.
Not, and that might happen if they don't do the initial home visit, which we're sort of working through right now, actually. Not everyone who's getting, not every household has to get all of the household interventions. Like, we're not going to impose it on them. Like, you have to call for free tax prep, right? We're not going to do that. But we're going to make sure we've offered enough times and reduce any barriers to act. But yes, in theory, the intent to treat is at the cluster.
Got it.
The city of Philadelphia is doing it.
They'll be helping us with abandoned home remediation.
What
And
is the difference from what they're supposed to do?
it's not, we're gonna just target their, so they also are oversubscribed. And they've been remediating a lot of abandoned homes over the last like 5 years. And so we're just directing their efforts to in sort of like a staggered fashion to our treatment group versus the control. They actually just did an RCT with Gina, where Gina randomly kind of, they had a list of homes, they did a random half of it, and then Gina has looked at the impacts on crime rate. And I think that paper is coming out at some point, but that team has found that it reduced violent crime by 20%. So actually, that's a good point. We are getting to that. So just remember that 20% number. So just to tell you why we picked these components, in Philly, they work. So individual components, let's start with the environmental one. This is what vacant lot greening looks like. These are, this is from a prior study of Gina. And basically, here's the before. I'm sure you have driven past lots or walked past lots like that. PHS gets involved, Philadelphia Horticulture Society, and then it looks really nice after that. That intervention has been tested in 2 trials. One is by Charlie Branitz and Gina, and then Gina has another paper, which I think was like one of the best papers I ever read in the journal JAMA Network Open. So basically, they found that people are using green spaces more. There's less self-reported crime and depression. But if you look at the far right-hand side, 28% reduction in nuisance calls and 29% reduction in gun violence. Those are objective measures of both those things, 311 calls and city crime data that they looked at. So it's both subjective perceptions of crime and objective perceptions of crime. They show these huge benefits. And this is the house remediation piece that I was telling you about. But in their RCT of house remediation, they found that all of these things declined a lot. And then trash cleanup also had some negative impact on one of the things, which was gun assault. So these environmental interventions, making places better, tend to make places better in other ways too. Go ahead.
So is the house remediation occupied housing or unoccupied?
Abandonments. Yeah. There's a version, there's like also indoor remediation, like, you know, there's lots of houses may have hazards, like lots of dust mites, they may have there may be termite damage, there may be like old electrical or water. Like, we're not going to get involved in that. That became too expensive and hard to identify. But that's a good distinction to make. So the benefits of individual components, if we look at financial interventions, we know from a lot of work that making it easier to sign up for benefits makes more people sign up for benefits. So they're able to actually access these programs. A lot of our work has looked at this on the state and national level, but it applies to the city level too. And we know that participating in the program can improve health through a number of different channels. George Dallenbert and his team has a medical financial partnership between CHOP and some of the community partners that I just mentioned. They were able to, in their early efforts, prepare almost 350 federal tax returns. That was about, if you look at the average client return, it's about $2,300 back to individual households. So that's a big bolus of cash. In some cases, it was as high as $6,000 or $8,000. This was prior to the child tax credit era, and I guess we're now post that era at some level. But if that were to come back, you could imagine that there are these even additional massive benefits that people can have. And we know from some data, and this is an active area which we'll talk about later, but there is evidence that cash transfers can improve mental health, at least if you look at all of the evidence across the board. Okay. So I'm going to talk about why we included a control group, because I just finished telling you that all of this stuff works. So the first question that comes up is, why would why are some people not getting? So we have a lot of reasons. So the hypothesis we're testing is not that any one of these interventions work. It's that fundamental cause theory implies that all of them will work synergistically in a way that we have not yet seen, because we have never really bothered, or we've actively tried to avoid investing in these types of things. So that's what we're trying to test. So that's number one. And number two, we're also trying to test new ways of delivering existing services. The Benefits Data Trust, the folks that sign people up for benefits, what they do now is they send out a mailer. And like, based on that mailer, people can call the number and then they can talk to a representative of BDT. The mailer has about a 6% take-up rate, right? So they're sending out lots of mail, and most people are not actually responding it. They've never actually brought their services to the door. That's what we're doing. So we're also testing some of these components in a new way. The reason why, so someone else might say, and I didn't put this up here, the reason why someone, you might still want to have a control group that gets something is that, well, if you're testing synergy, then you can just have a control arm that gets like, like a fraction of these things or one of these things. And the reason we can't do that is that we just don't have the budget to do it. Like I said before, the community partners are overprescribed. So they're not able to actually treat the control group. We had talked about that. And so what we're doing basically, and how we justify this ethically, is that the budget was not there until we were able to obtain it. We actually got less than what we asked the NIH for. And so our control group, necessarily the ethical thing to do in the situation where we have resources that are limited and we're testing a potentially important scientific hypothesis, is to randomize. That's kind of the architecture of our argument. It's important to tell you that the control group, there's a lot that's happening in Philadelphia. So going back to abandoned home remediation, that's happened, right? Like the city's doing it. So we're not going to stop that from happening in the control group. They may be accessing VDT. Like one of the community partners may decide we're going to do some new campaign to get people to sign up for free financial counseling. We're not going to stop it. People in the control group happen to access these things as part of real life, and the city's doing what they want to do. We're not getting in the way. Right. So there's still a lot of programming happening in these communities. We're not leaving them astray, and we're not preventing people from getting. We also want to make sure we compensate them more than fairly. So one of the things we've told everyone is that, there's multiple surveys and people can earn up to $125 for these surveys over a 2-year period. And at the end of the study, every single resource that we have made available to the intervention group, we're going to inform the control group about it. But most importantly, we're actually working to secure additional funding to get control group participants some of the stuff that we're doing. So we will have the ability, I think, econometrically to get a general sense of what components may have been most effective or not. And then we will try to direct our resources, whatever we have at that point, to the control group this. So that's kind of what we're doing with the control group. And typically, this is where most of the concerns have been raised about. I don't know if you all have any thoughts.
If this were a drug study, for example, there'd be an expectation that placebo patients would get some kind of like open label access to the intervention after the trial.
Yeah.
Would you contemplate? It sounds like you just didn't have the funding to support that.
Not in the initial NIH grant. So to do that, that's what we're trying to get additional funds for. I mean, what I think whether it works or not, we have individual interventions do seem to work. So we would want to expand access to them best we can. Yeah, that is the ideal. The other thing that Amy Finkelstein and others have talked about this when evaluating social programs. The other thing that you could do is the control group, another way to test whether there's synergy between like environmental and economic justice is to basically have like a cash equivalent arm. So we take whatever money is going into the community that we estimate, and then we divide it by the number of participants in the control group and say, this is the cash equivalent of this like other thing we're doing in the treatment group. And so increasingly, especially in the global health literature, where I think there's been like N number of unconditional cash transfer studies, the control group in a lot of those studies tends to be a cash only arm, and then the treatment is like some sort of combination of things to kind of move people out of a poverty trap. So that is something we could do. We did not do that for 2 reasons. One, we could not afford it, but I think the better reason is that there are actually at least 20 trials. If you go to guaranteedincomeus.com or something, there's like at least 20 trials now in the United States that are testing guaranteed income, basic income type services. And so like there will be an answer as to whether how much cash moves the needle when it comes to health. But we don't have that answer. So to have it in the control group seems like that's like something actually that's being tested. So it's not like really a fair comparison. And we also wanted our trial to be in conversation with the cash trial, right? Like this is happening. I think there's some other interesting trials that I think the City of Philadelphia Public Health wants to do. But all of that will yield treatment effects that we can compare to the treatment effects from a cash trial, of which some are happening, I think, in Philadelphia. So we want like clean comparisons between those because it's important to know how to best spend the cash. I would say fundamental cost theory implies that you need to do more than cash, but that's one of the things we'll learn in the next few years. So cash can't be the control group for that reason, in my view. Okay, So there's still the possibility that we could mess it up and be very top down. So we thought about this too. One is we're asking people to do all these interventions. Like, how rigid do we want to be about that, right? It's, part of it is that we don't want to be too timid and say, like, here's your interventions, do them. Like, we want to make sure people can engage with them, because there may be barriers. Even if we go and like knock down some barriers, there may be a last mile barrier that prevents people from calling VDT or having their taxes done with the CFW. So we want to be a little aggressive about making sure people can get it. But we also don't want to force them, because people will make rational decisions when they can about like, hey, like, I don't need to do this one. Like I'm in a pretty good financial position. And so we've been thinking a lot about where do we want to fall, and this is coming up right now. So we've kind of fallen on the side of we'll have multiple points of contact, a home visit, we'll kind of reiterate the benefits, but we will have a hard stop where we'll say, you know what, you don't have to do this one, we've tried this many times. And if people pick some subset of these things, that's fine. So that's something we're trying to protocolize, like how far do you want to go to like eliminate the burden, the burdens that may be there that prevent engagement with these services versus like, how far should we not go before it becomes annoying and potentially disrespectful and has opportunity cost? Like people could spend their time doing other things rather than our program. The other thing we have is that we have set up as a mechanism now weekly that the community coordinator team brings any concerns they have from participants or in the field to us. So we're constantly hearing about how things are going. And that's important to us because if things are not going well, or if there's questions or there's lack of clarity, we want to be able to answer those in quasi-real time. The last thing we did was we went and proactively presented this to the West Philadelphia Promise Zone. They have a watchdog group, the Community Research Review Board. It's basically the type of group that will hold researchers accountable for projects that are happening, at least on the West Philly side. So we had a 2-hour presentation. We answered a lot of questions, and they gave us enthusiastic approval at the end. The one concern they have was that the study team did not necessarily reflect in a diversity sense the population that we were trying to serve. So that was the only concern they had. It was a minor concern, they said. And so we tried to go through that additional channel just to be sure that we were getting things right. Okay, any questions with that? Cool. Right. So I can tell you what we're measuring, how we're measuring it, and some analysis type of concerns.
Sorry, can I actually ask
Yes.
this question about the previous slide? Can you give a couple of examples of the kind of things the community coordinator team is hearing? Like what kinds of concerns are bubbling to the top so far?
Yeah, so one that that we were just thinking about this morning. So we have like a script to introduce the trial. And the script is like, you can earn this much money and stuff like that. And so one of the things that happens is that after they go through the script, then it's like, you have to check the eligibility. Is your address in our ArcGIS map of a cluster that is been chosen for the study? And sometimes the answer is no, they happen to live just outside of it. And so there's this interesting thing that's happening where some people have gotten upset because they heard all the spiel. It's like, I get at least $125. And then they hear that, oh, actually, you're not eligible. And then it's like, wait, you're taking away my $125. So on the 11th floor, that's like a great example of the endowment effect. And so this is one of those things that we're dealing with, but it's like, you don't want people to feel bad in the moment. Like, we don't want to be in a position where we look like we're promising something and then at last minute taking it away. So we've changed our workflow to avoid that situation. I did not expect it to happen, but this is the kind of thing that we.
So you're looking now at eligibility as the first part of the conversation. Yeah.
Yeah, it's like, hey, let me check your address first before I tell you. There's also like a time, it's like it takes 4 minutes to give the spiel. So I don't know, like 4 minutes is a lot. You could use that for something else. So we also wanted to preserve that, but that's the kind of thing we would not have learned had it not been for.
And you may be getting to talk about this later, but in terms of consent, are you finding that anybody's saying no, or like what are your consent rates?
I'll show you in a second.
You will, okay.
Yeah. So we are simultaneously, there's a ton of interest. And I'm curious to see now how it goes after the World Series ended. People were enthusiastic for lots of reasons. We had a lot of interest, but our enrollment is also proceeding a little bit below goal because I think we're spending a lot of time. correctly telling people about what the intervention. There are lots of people who will say things like, hey, let me tell my neighbor about this. So there's good word of mouth spread too. That's a great point. I mean, oh, Kat, before I answer.
I just had a quick question about how you pick where the clusters are. Are you controlling for like gentrification possibilities? Because I know if you compare that 2019 map with 2009 map, it would be very different.
Yep.
And I'm just wondering, like, a lot of the environmental steps are things that I've seen right as gentrification happens in the community. I'm just wondering, like, are you making sure that like developers are not buying up space in the areas that you're concentrating on?
Yeah, that's great. So there are two questions there. So the first question is, how do we choose the community? So I forgot to mention this, but what we did was we took all the tracts in Philadelphia and then we ranked them by poverty rate. And then we ranked them by percent Black. And we basically sampled that. So it's 300 something tracts. So we ended up with 100 and change tracts that were predominantly Black, so like over 80%, and had poverty rates above like 25% on average. And all of the neighborhoods are from there. So we sampled, I think 1,000 different universes of clusters drawn from those census tracts. And then we had some parameters about the space between clusters and things to avoid spillovers, to make sure that they're kind of distinct and they have enough vacant lots. They're not primarily resident, they're not primarily business, commercial, they're mostly residential. So after we did all that, we arrived on the 60. Your second question is a great one. So this is the kind of thing that I think like we had to look at past experience. And so from what we know about abandoned house remediation, Gina's research, vacant lot greening in particular, is that there hasn't been this response where there's been in-flight of like new residents, out-flight of old residents, and like commercialization in these areas that they've already greened. They're hyper-local, like eighth of a mile. It's possible that at this scale, with so many things being done at once, that those dynamics could take hold, and we would be, we're tracking moving as one of our outcomes, and we're going to look at the track level for some of our outcomes. But so far in the, I think, 8 years that they've been doing the environmental interventions, they have not seen huge evidence of turning this, the neighborhood beautiful or whatever, or cleaning it, and then having the composition of it change, or like reaching a tipping point where. So that's, I think, so far we haven't. But point taken, on a large scale, you might imagine this happening, and like there, it's complex because these types of interventions can raise the property value of homes. Many of, almost all of those homes in these tracts are owned by Black families. But we also know that in real estate markets, Black families command less wealth. There's like discrimination in how homes are valued. And so like, how big is that benefit? So I think there's just a lot of complex dynamics we can't predict. We have to keep an eye.
Athene, we have a couple of interim questions from the folks online.
Oh,
So
cool.
I'm gonna read. The first is from Lakeisha David, who says, I can't help but think about the broken windows theory. And she asked whether you consulted with urban planning researchers and community development, and to what extent do you know about the history of Black Philadelphia?
Yeah, so I think there's a lot in there, but so starting with the broken windows theory, the work on abandoned home remediation, I think in some ways is like the inverse of that. That by virtue of like actually intervening on the broken windows, in some cases, literally that's part of the remediation, you actually see these reductions in crime. So there seems to be some support in the, whatever the inverse or the converse, I forget my high school logic, which that one, but you can, if you undo the broken windows, you can actually have some positive effects on that community. Charlie has deep expertise in urban planning and public health of urban spaces, and John is a criminologist. And then Gina has been working with them for many years. And so a lot of the historical aspects and some of the theories from criminology and urban planning that informed the study come from their work, actually. So I'm not the expert in that. I can't comment beyond that. We were careful to make sure that that was represented on tape.
Great. And then we have one more from Marie Stoltz, who says, can you talk about the idea that the people you included in the study with the photos earlier in the study were predominantly not people of color? And then when the West Philly Watchdog Group said this was a minor concern, did they say anything more about that? What additional feedback did they provide?
Yeah, so it's really, it's a good question. So I think that's something that over time in the aggregate across all these studies, we'll just have to try to figure out what is our goal with diversity. And so, you know, in our team, Gina is identified as Black American. I don't, and we're leading the study. And then in terms of our co-investigator pool, we have varying racial, ethnic, and diversity by gender identity. In the co-Is and the PIs, I think we wanted there to be good racial diversity, but we also wanted there to be intellectual diversity. And part of it is we wanted someone to check ourselves, right? It's great. We need someone with urban planning expertise on the team. And so we were trying to maximize across multiple different margins of diversity. And I think we've tried to do that at every level of the study. I think where the promise zone was coming from is they had a different objective function with diversity, which is the study team should look like the participants, which would imply a much different racial and ethnic makeup. You know, it's interesting as I am the one who's being asked to answer this question, but I think you can see merits for both, and I think there's a larger conversation to be had about what is a diverse study team that is most respectful, most attuned to the potential harms, but also most attuned to the potential innovations in communities that haven't had active innovations like that. And I think it could take all shapes or forms. That's not to say there's a trade-off between racial and ethnic diversity and other types of diversity. It's just like we just have to think carefully about what we want. We did, and this is what we came up with. I think some people may agree, some people may not agree. You know, I think we were all for those of us who are not part of the community in any sense, I think we were careful to be deferential and humble where we can. So, you know, like Gina and I have very different, we both had the study, but we have very different styles of leadership, very different roles and engagement with our staff and the community. And like we keep it that way, I think intentionally on purpose, because we don't want to overstep the bounds of lived experience, intellectual experience, and what the community may want from us. So it is really hard. I don't know if I've answered that question, but like I
think you've more than answered. I think we can go on.
Okay. So outcomes. So we've powered for two primary outcomes. One is an overall health index, which is a series of questions about self-reported health that get at both physical and mental health domains. They tend to be validated and correlated highly with mortality. So we're not going to be powered to look at like hospital admissions, right? 720 people. But what is a good proxy that actually predicts the kinds of outcomes we might care about for our participants down the road? Something like that. We also have a psychological distress scale. It's the Kessler-6, often used. In my experience, these types of interventions tend to move psychological distress exquisitely. So in all the work we've done and the work that Gina's done, all of these interventions like make people feel better in this very tangible way. And for folks who, these are census tracts that tend to run younger for a number of reasons. And for younger folks, actually, you tend to see more movement on psychological distress than you do on physical health. So we're doing both of these. We have a number of secondary outcomes. We're going to ask about stress, future aspirations, exposure to violent crime, a scale for financial security, their social connectedness. Are they going outside and using green spaces or not? What do their finances look like? And are they using the services that we're providing? And some healthcare utilization. So we're trying, if you go back to that, I should have actually put that here, but I had that diagram with all the arrows and all the mediators. We're trying to measure all of them, right? So this is all from theory that we developed. There will be a qualitative part of the study. It's going to be about 100 participants. This will be the most exciting thing, I think. It's exciting. I'm not a qualitative person, so I don't have to like do it. But I get to read it, which is, I think, often everyone is better served if I'm in that role. So it's going to be 100 people, a bunch of people from the study, both the treatment and control group. But we're also going to have people from the communities like block captains, other community organizations, policymakers from the city, and then other stakeholders like like the NGOs we're working with. And what we're trying to get a sense at is the why. How is the intervention perceived? Why might it work or not work? And what are the challenges to implementing it at various different levels? So we're super excited about this. And the community coordinators, like as part of their red cap capture of the survey, have all these interesting things that they found about like what people think about the study and so forth. So like to systematize that in a qualitative study that Megan Lane Fall will lead is going to be fantastic. And I think if you think about this, this is kind of, did it work? Why did it work? Why did it work? Plus, what are the implications for all of the other parts of the country that might be interested in doing something like this, right? Like that's where the biggest learning is going to come from when it comes to scaling. So that's how we've thought about that. Internal to external validity is kind of our.
Athene, there was a question online about how you're defining household, because some of these are like more individualized measures
Yes.
versus community level measures. And so they ask about, is it everybody who lives in the house, only adults, kids, grandparents, who's included?
Yeah, that's a great question. So I did a little sleight of hand. So it's going to be 720 people from 720 households. They will be answering these questions, some of which are individual level and some of which are kind of household level questions. The intervention necessarily benefits sign up, taxes, and financial advice. All of that will be at the household level because the finances are connected as a unit. So we intervene on the household, but we're asking individuals questions.
Great.
So we are doing this now. We're fielding a 45-minute survey with all those questions, and we'll do that 24 months later. That's what's in the budget. We're also going to use administrative city data on crimes and 311 calls. We're looking into things like school test scores and other things to expand the study, hospitalization data, but we didn't put that in the protocol yet because we don't have it. We're going to be very safe, and the analyst is not going to be aware of treatment assignment. And both Gina and I and all the co-Is, with the exception of the bias statistician, will not touch the data. So that's like hard for me, but I won't be able to do it. But whoever is doing this is, like we can't preserve blinding at the participant level. We also have to know where the treatment clusters are because like there are things that happen that are unique to each cluster. We have to be aware of all the safety issues, whatever it is. But the data will be out of our hands. And so then it's going to be, we're trying to protect ourselves from messing up the inference. Okay. So primary and secondary outcomes is just general. It's like you're comparing means between two groups. We'll just use like a general estimating equation structure to deal with the fact that we have two outcomes. We'll cluster at the 12 different individuals from 12 different households in the same cluster. It might have some correlation between them. We'll cluster there. And then we're going to do some stuff where we look at specific subgroups, which we pre-specified. We're going to have data from the community partners about take up of program use. So we're going to look at that. And then we're going to try to tease out the best we can from this overall treatment effects of like individual parts of the program. So it might be that someone who's at baseline does their taxes every year will not benefit from a free tax preparation service, right? Because they're doing it anyway. It might be that some people are already on all the benefit programs they'd be eligible for, so would not be eligible for PDT services. We can use that baseline variation and interact with the treatment indicator to try to get a sense of among people who actually could have used the services because they needed it at baseline, did you actually see differences in health? So we're trying to build that in. It will all be underpowered, but it will be suggestive, and that's why it's kind of an additional analysis. You can use the QR code if you want. That'll link you to our clinicaltrials.gov page. There's actually a PDF which has the whole trial protocol specified. So if you're interested about any of the nitty-gritty stuff, you can find it there. This is not this is out of date now, but we've enrolled, I think, close to 90 households. We're going to be completing our 8th of 60 clusters. You can get a sense of why people may or may not enroll. So like we go to a lot of houses, people have to be home. Typically it's after 4 o'clock. And so when they start getting home, and so this was just, I think, this isn't actually data for all the clusters, but you can see that we're enrolling, a pretty fair share of who we're getting. So like, we're not expecting to like unroll 100% of the people whose doors have been knocked down. We're not expecting to even enroll 20% of that, but we're actually right around the 30% mark, which is pretty good when your denominator is everyone. So everyone that you've knocked on. So that's why we think there's demand for this. Okay, so this is also important. We have thought a lot, and the community group actually was very interested in dissemination. So we've thought a lot about this. You can find our protocol again right here. I'm doing this because it's the first time I put a QR code in the talk, and I want one of you to use it anyway. So you can use it online. Just rewind. So what we'll do after we do the final data analysis is we're going to present to the same groups that we've been talking to this whole time. There's also a group in North Philly that we're talking to. We'll present it at places like this, academic seminars, there's the journal articles, but we want to create like policy briefs and visuals so that people can learn from the study, right? Like it'll be a standing website, what worked, what didn't work, what did participants say, what can you do better? And like we want to be really transparent so that if someone in Detroit wants to run something like this, they will be able to learn the Philly experience and do their best at exporting to another place. We'll make our data and code available, obviously. And I think if we're intentional about dissemination, we will be in a great conversation 3-4 years from now with the people who are doing basic income trials, with the people who are doing other financial service trials, other environmental trials. There's going to be a lot of treatment effects from a lot of cities all across the country. So there's this opportunity for an incredible, I think, exercise of learning about what works and what doesn't and why it might work. So we're hopefully, if all this works, we'll be able to contribute to what I think is a very exciting time in public policy. Okay, thank you so much. Any questions? I'm happy to answer them.
Okay, so those of you who are online, please feel free to enter your question into the chat. Those of you in the room are welcome to start asking questions. In the meantime, I have one follow-up question on that household level
Yes.
intervention, and the question was about the micro grants. Who within the household is deciding that there's a particular need that would, who can request the grant? I suppose that's the question might be getting at.
Yeah, and so we struggled with that. How do you request for that? Who can request for that? And now the decision is as long as you're able to, like clarifies the organization that's going to be providing the micro grant. As long as you meet with them, you will just get the micro grant. Like we're not even going to like go down this whole thing. $400 of it.
But anybody at that address could ask for the.
Yeah, it'll be the survey respondent is the one that will be the person who
Okay.
will get that. Yeah. The intent is that it's for the household. And we know from I think studies in like other settings that there's always this concern about giving cash to like an individual person. What are they going to do? And like, is it better to give it to a woman or a man or like, so there's all these trials from all over the world. Generally, almost always, this came, I think, from like a paternalistic bent that development folks tended to have for many years. But what we find is that people know how to use money. So like, we're not that concerned with how it's being used. It's going to be used for what they need. And it'll spill over into the house.
Can you say a bit more about how the institutional review board, the Penn board, responded to this project? Did they raise any concerns similar to your LinkedIn friend, or did it kind of go through without comment or concern?
It went through without, there was very minor clarifications of things I cannot even remember. It went through fine. Yeah.
Other questions?
Oh, yeah.
The third part of your outcomes, the sort of community element of it, are you thinking about sort of like the community integrity board, like the implementation of that unit? Is that throughout the study, or is that like an outcome of what happens here?
So that part of the implementation study that's what you're asking about, that's going to happen during the study. Yeah. So the implementation piece, I think, so we'll be enrolling till April 1st. And while we're enrolling, some of the financial services will be making those links. the environmental interventions all start on April 1st, 2023. And then that will be ongoing for, because it has to happen in the spring to plant a tree and stuff like that. So that'll be going on through the summer into the fall. And in the fall of that, right around September, what month is this? November. So 10 months from now, I think, is when we'll start getting the implementation piece done. It's enough time for some of these environmental interventions to be complete in many clusters. Almost everyone ideally would have cycled through at least one of the financial partners, then we can start. We'll have experience on all sides of it.
So I don't know how strictly you're adhering to FCT, but just a theoretical question about that. Have you thought about or anticipated what mechanisms might move into place as you're addressing even multifaceted?
Yeah, that's a great point. So I think the point you're getting at is like, it's not all of the mechanisms, right? So I told you I have to intervene on everything. And then I said, here's what we're intervening on. But you could imagine other things that one could intervene on. One that came up when we talked to some EAB, maybe I don't know if it's a department or it's CHI, but someone on a separate call brought up like, none of this is going to work like if you're not giving people jobs. And so, we don't have employment opportunities. And my lab actually just studies the effects of employment opportunities, real or perceived, on people's health outcomes. So yeah, like that's in our mind. That's something we're not doing. Do we anticipate that there's a change to the labor market that responds to these specific interventions in ways that might clamp down any treatment effects? I don't think so. So we couldn't draw that arrow. So it's possible. Kat's point about gentrification is a mechanism that could arise to undo some of the benefits. So we'll be watching that. But yeah, we unfortunately we couldn't intervene on everything. If you think through the literature on reparations, right? There's a great paper by Elora Daranancourt about the racial wealth gap, which is at some level what we're all trying to address. In that paper, giving whatever the reparations transfer is to a Black household in isolation is not enough if you don't deal with the fundamentals, which is what is the discrimination in labor market, housing market, and other things. So like you can equalize the gaps and it'll only open up over time. There has to be there has to be some extra stuff that needs to be done. So that is if you think of the scale of that transfer, what it requires to deal with almost all the fundamental causes that you could think of, we just don't have the budget to do it. So we had to pick what are the top line things that we know in Philly will work that are local enough that don't elicit general equilibrium effects that could screw up the whole thing. And these were the ones we came.
And did you have?
Oh, no.
Oh, sorry. I thought you raised your hand. Athena, I realize your grant is 5 years, and at the end of 5 years, it's going to end then. But have you thought about the sort of sustainability and the kind of half-life, if you will, of the intervention that you're putting in place? And if you have the opportunity to sort of go back for follow-up funding or forever, how you might measure sort of long-term effects or extended effects beyond the actual period of your grant? What are the sorts of things that you might want to look at?
Yeah, so I think the big thing that we want to look at is, so ideally what would happen is after 2 years, we would get everyone in the control group on board with the same intervention. Let's say for some reason that doesn't happen, we could procure a lot of other funding. We would use the funding in part to do that. So if it's a 2-year window, like here's 2 years versus not 2 years, it's harder to look at long-term effects there. You could look at children who are between the ages of 0 and 4 or 5, because you're intervening in a critical period there. And then you can trace out the long-run effects of having it in this critical age versus not. And so that we're working with Aditi Vasan at CHOP and trying to get Independence Blue Cross to sort of, and some other partners to fund Ignite for kids, which would basically be trying to trace out some of these short and long run effects. If we had to stop everything at 2 years, then we'd want to go back and see, were some families in the treatment group able to exit poverty? So did we actually allow them to ascend the poverty trap? Not ascend the poverty trap, like get past the poverty trap to a kind of a more financially secure equilibrium. And I would imagine that some might, especially the households that relative to the other households are a little more advantaged, like this extra piece could move them, but we just don't know. So it's hard to say. I think like we're trying to, at first thing is we're trying to make sure that we can get the services where they need to go. But with the kid study, at minimum, we'll have that parameter, which I think will be useful. And if we can't do any of that, then we might just try to get funding to go back 3-4 years from now and see what happens.
Okay, we are actually out of time, so thanks to Athene for. And Athene,